We performed a sub-analysis of a PROMISE trial. As the listeners may know, the PROMISE trial is a large randomized trial that randomized 10,000 patients into either coronary CTA, anatomic strategy, or functional testing. And this was a secondary analysis that looked in anatomic strategy at patients that received coronary calcium scoring. And we know that coronary calcium in asymptomatic patients is a very good predictor of events. However, there's much less data in terms of predictive value of coronary calcium in symptomatic patients presenting with suspected coronary disease, and there's virtually no data comparing predictive value of coronary calcium to functional testing. So the aim of our study was to first look what the predictive value of coronary calcium in the symptomatic subjects is, as well as to compare this to functional testing. So we studied approximately 4,200 patients in functional arm with calcium scoring, and we received calcium score in those patients. And then we have 4,600 patients in the functional arm that received functional testing. We stratified the results of the test. On the coronary calcium side, we stratified the no risk or very low risk patients, those that have zero calcium, no coronary atherosclerosis. And then we looked at the strata of coronary calcium, mild 1 to 100, moderate 100 to 400, and overall 400 severe coronary calcium. Similarly, we classified the functional testing strata as well. Functional testing was normal, it was completely normal. Mildly abnormal, where there were mild abnormalities but no significant ischemia, and then moderate or severe amount of ischemia as moderate or severe functional testing abnormalities. First of all, we observed that there is a relationship between extent of calcium and the outcomes. Major adverse cardiovascular outcomes, which is primary outcome, was all-cause death, non-fatal myocardial infarction, and unstable angina requiring hospitalization. So again, across the strata of 0, mild, moderate, severe calcification, we saw a gradation of risk of events over approximately 2 years follow-up. When we looked at the comparison between calcium and functional testing, there was this very similar gradation of risk from no mild, moderate, severe calcification, as well as no normal, mild, moderate, severe functional abnormalities. Overall, AUC was similar in functional testing and calcium scoring, 0.64 for functional testing and 0.67 for coronary calcium testing. However, when we look at the more detailed data, we show that 82% of events happen in those patients that had coronary calcium, and only 18% of events happen in those that had no calcium. As compared to functional testing, where 56% of events, 57% of events, actually occurred in patients that had normal, completely normal functional testing. This resulted in a much better sensitivity of coronary calcium scoring for prediction of events, sensitivity around 82%. However, the specificity was much higher in functional testing because there were more positive predictive value in functional testing, and functional testing has specificity around 79%, whereas specificity of calcium score was only 35%. And again, this resulted in overall similar discriminatory capacity for MACE. In summary, what we found was that these tests predict future cardiovascular events, both calcium score and functional testing, and potentially high sensitivity of calcium scoring may be a new avenue looking at first calcium scoring and then adding either functional testing or CTA imaging to further risk stratify the patients with symptoms. I think, first of all, we know now that even in symptomatic patients, calcium matters. So when we receive calcium scores and we'll look at it as a predictor of future events, they should be taken into account when we are reporting, when we are evaluating the patients after receiving the test. Second is, again, this potential for future study, testing calcium score as the first test. Of course, calcium is much cheaper, much easier to perform, doesn't require a contrast agent, so could be a potentially first test to evaluate the burdens of atherosclerosis and evaluate then further with additional, more expensive tests after that. We also presented data from a CT arm of the PROMISE study, analyzing actually in the core lab CT angiography data for the presence of high-risk plaque. And it is well known that the stenosis is a good predictor of future events. There is also growing data, mostly from Japan, showing that high-risk plaque features such as positive remodeling, spotty calcium, low attenuation plaque, or napkin ring sign are predictors of future cardiovascular events. We analyzed over 4,400 patients that received the angiography in PROMISE trial and showed that indeed the presence of high-risk plaque in PROMISE trial was a predictor of future cardiovascular events. Again, non-fatal myocardial infarction, unstable angina, and overall death were predicted by the presence of high-risk plaque. What we had shown also was that the high-risk plaque was independent of stenosis and ASCVD risk score, Framingham risk score, so cardiovascular risk factor burden, showing that high-risk plaque is incremental and additive, incremental and independent of traditional assessment. This sort of opens a new avenue in terms of risk stratifying patients with additional imaging markers of future cardiovascular events in the future. What we will need, of course, is to see whether or not we can find therapies or interventions that would change the outcomes based on our imaging features, and that's hopefully the future of this field.